In this part of the podcast series, I talk about facial assessment of the aesthetic patient. There are different ways of going about a facial assessment, and it's not this podcast that needs to go through all the minutiae or bare detail, but it's to give the listener, many of whom will be aesthetic practitioners, potentially starting out in their clinical practice or diverging from other areas of medicine, dentistry or nursing, and wanting to find a more targeted approach to get the most out of the facial assessment to achieve the best aesthetic diagnosis. This is time that is extremely well spent, and Sir Harold Gillies, in the turn of the 1914 to 1918 period, felt that really the history and the examination led to the most accurate way of diagnosing patients' conditions, and the best diagnosis would lead to the most effective treatment. Over 100 years on, that statement is still very, very true. Actually, however, not everybody has the ability to pick up the same things from a patient examination. And if we lined up 50 new aesthetic doctors or trainees and asked them to do a blind history and examination, we would probably get 50 different approaches to facial assessment. As is the quote from Confucius, everything has beauty, but not everyone sees it. And this breaks down into when we assess a butterfly and a moth. While they are two different species, one is considered highly beautiful, while the other one is considered an insect or a pest. However, they both show golden ratios in their wing form, but their colour differentiation often means that the butterfly outweighs the superiority ranks, outweighs the beauty of a fairly dark and bland looking moth. Leonardo da Vinci called this a saber verde, knowing how to see. So in the next 10 to 15 minutes of the podcast, I'm going to hope to instill just a little knowing how to see based on my own principles. Every face is different, and although we like to see aesthetics as an art, however, we have to understand aesthetics as a basic science and at a mathematical level and at an anthropometric level. Patient interview is clearly very, very important on identifying patient's age, their associated gender, their medical history and social history are all vitally important. The motivations for seeking treatment, their expectations, their realism, and what their perceived concerns are really falls in the very first phase of history taking by identifying their presenting complaints, their treatment goals, and whether, as a practitioner, your expectations and treatment skills match those of the patient. It's also a really valuable time to spot those patients who you'd prefer to refer to a colleague further down the street or across the town, that you know are not going to match what you can deliver. And this is often an inherent skill, or as we would call a gut feeling in the UK, that comes with time, judgment and clinical experience. So realism regarding expectations is very important. and whether or not there can be a cooperation between both client, patient, and practitioner. I want to kind of move away from the history once you have gathered the key parts regarding medical history, drug history, making sure they are not on any medications that might increase the risk of bleeding complications, increased bruising, potentially immunocompromised, recent COVID or COVID vaccination status, previous allergy history, and also critical in patients being injected around the face is a dental screen to determine if they're undergoing any active treatment or had any recent dental infection. I see a number of complications that present or referred to me in hospital where patients actually have some active dental sepsis, which is intermittently on a daily basis causing a bacteremia. However, they've been injected with hyaluronic injectables without precautions of sending them to the dentist first to address the sepsis. So those are a few pitfalls of how to navigate safely. Let's move on to the clinical assessment. And we have the patient sitting in the consultation chair or on the examination couch in an upright position. Men and women with long hair have this carefully positioned behind the ears, allowing a full frontal and a profile assessment. The very first thing that I would recommend is to make sure the patient is orientated correctly. So looking at a line dropped between the center of both pupils and assessing that this line is horizontal to the ground. The next is a line that we've routinely used in dentistry and in orthodontic assessment. Is what we call the Frankfurt mandibular plane, or the frontal plane for simplicity. And this is a horizontal line in the profile position, which is traced from the superior edge of the external auditory meatus, crossing and bisecting the inferior orbital rim. By placing the patient in a frontal and a profile position in this way, we get an excellent understanding of the patient's proportions. So moving on, we are then able, and I typically approach the patient from a profile position first, and this I prefer because it's a non-threatening. Staring at a patient with great concentration front on can often be disturbing for a patient initially. They have to familiarize themselves with the surroundings and build that trust in the clinician and the nursing team around them. So from a profile assessment, I glance down and assess the facial thirds. This requires identifying the distance between the brow and the anterior hairline, a point from the glabella or the brow region to the base of nose, and from the base of nose to base of chin. Fundamentally, this should be addressed as thirds, or lower face ratios from brow to base of nose to chin should be at a ratio of about 45 to 55 in white Caucasian. This can be a little bit more of a ratio, 43 to 57 in Afro-Caribbean faces. Once you've achieved the dimensions, you are then able to look at various angles. The frontonasal angle, the nasolabial angle, the labiomental angle, the throat angle, and from there you're able to break up assessments into upper face, mid face, and lower face. Upper face allows you to discuss the proportion and the contours of the frontal region. Women tend to have a flatter, more vertical forehead, turning late into the hairline, while as men have a softer, more acute angle from the supra brow area, curling back into the hairline. The skin quality, whether there are dynamic or static rhytides, any scars, skin quality, sun damage, sunspots, or any dermatological condition. It's often in patients from 45 onwards that you may be one of the first clinicians to spot a mole or an early basal cell carcinoma that will prevent early injectables but a rapid referral to a dermatological surgical service. There is also the opportunity at this stage to assess the hairline, whether it's a good anterior hairline, whether it's receded, widow's peak, male, female pattern hair loss. The next stage is to assess the midface from the profile region, and this can be broken down into midface and nasal areas separately. Nasal projection, dorsum of the nose, nostril show, projection of pronasale, and position of the columella in relation to the alar region can all be assessed laterally. The cheek should also be assessed for its contour, its light reflex, and a light reflex high up on the cheekbone, which is concentrated at a level approximately 2 centimeters below the lateral canthus. If you drop the Blythe line from the middle of the cupid bow across the cheek to the superior margin of the pinna and drop a line 1.5 to 2 centimeters from the corner of the mouth, falling on that line should be the ideal light reflex. From there you can also assess the distance of the cornea and conjunctival surface to the rhinion and nasion. This will help you identify the position of the globe and also the position of the anterior surface of the cornea in relation to the inferior orbital rim, and identify a positive versus a negative vector globe. And this will then give you some stratification later on down the line if a tear trough and upper midface augmentation is required, will give you some indication of the complexity. The lid to cheek relationship is also best assessed in the profile way. We would like a flawless transition from lower lid to cheek, going from a convex, a concave lower eyelid, sweeping gently into a convex cheek, a youthful convexity that is positioned maximum in the mid to upper third of the cheek and flowing naturally into the nasolabial region. Moving more laterally across the cheek, there can also be assessment of whether or not there is any inframalar or infrazygomatic hollowing. This is often a genetic feature and a desirable feature across male and female models in their 20s and early 30s. But in some circumstances, it can be acquired and achieved through unwanted weight loss, forced weight loss through eating disorders, and potentially cachexia. Surface features should also be assessed in the profile position, and that may be related to skin quality, sun damage, xanthelasma, crow's feet, excess skin of the lower eyelid, and it will also give you a profile view of any pseudoherniation in the lower lid. In relation to assessment of the lower face, we're ideally looking to assess the height of the upper lip to the lower lip, which should stand at a ratio of 1/3 upper lip, 2/3 lower lip, with the vermilion volume of the upper lip being approximately 1/3 to the lower lips 2/3. Some people feel that this is the golden ratio, where the upper lip measures 1 to 1.6 in the lower lip. What is also important, and what you can potentially do, and as a trained eye with time, with the patient in this frontomandibular plane angle, you can drop a line perpendicular to this line from the glabella region, passing through subnasale, which is a bony point at the base of the nose, at the transition point between the columella and the upper lip. And you can identify how the soft tissue lips and of the upper lip, the lower lip, and the chin relate to this line. This will give you an indication of the underlying skeletal pattern of the patient and any possible dental proclination from the upper and lower incisors. A skeletal pattern 1 is when the midsection of the upper lip is touching the line, while the chin point of soft tissue pogonion and is also resting on this line. In a skeletal pattern 2, the soft tissue point pogonion is behind the line, while in a skeletal pattern 3, the soft tissue pogonion is in front of that line. And there may be additional features that the upper lip falls behind the line in class 3, and there is a hollowing feature of the cheek representing a hyperplastic maxilla that may not have grown in an AP direction, an anterior-posterior direction, but also in a vertical direction. Therefore, the upper lip is short and retrusive in comparison to the lower jaw, which has grown in a stronger proportion to the upper jaw. Ideally, the labio-mental angle should be approximately 100 degrees, so there is a tight neck, there is no sagging of the skin, no ptosis of the chin, which we call the menton region. And the throat angle is where the submental line turns to a vertical, where the throat angle is in the region of the hyoid. Ideally, we're wanting a 95 to 100 degree angle. This is often lost, and the angle becomes more obtuse as we grow older, and there is laxity and weight loss, or a reduction of collagen, maintaining the integrity of the skin architecture as we get older. Low-lying hyoid positions may also influence this angle. Running into the neck, one may also comment on radial and circumferential rhytides, the prominence of the thyroid cartilage, which is an important feature to consider for transgender patients, running down to identify the thyroid region and any fullness. Again, with all examination, looking at the quality of the skin, the elasticity, and any unfavourable dermatology.